welcome everyone to Bangalore. I'll be presenting something on vernal keratoconjunctivitis, which we are quite regularly seeing in our cornea OPDs. Okay. As we just now discussed the types of allergies, a perennial, a seasonal allergy, and atopic allergy, which is usually associated with some systemic allergies as well. And like Radhika ma'am told just now, like a giant papillary conjunctivitis, usually common in contact lens wearers also. So it can be either a type 1 or a type 4 allergic reaction, hypersensitivity reaction basically. So according to Dr. Gokhale sir's work previously, the division or the grading of the vernal keratoconjunctivitis is extremely important. So in mild, moderate and maybe chronic cases, it might overlap like the symptoms and the findings, but the severe and blinding cases usually present with all these things and is a chronic and recurrent problem. So why do we focus so much on vernal keratoconjunctivitis? Basically, it is a very severe, recurrent and severe form of ocular allergy characterized by bilateral chronic inflammation, which can result in a permanent injury or visual disabilities if not treated adequately and recognized early. So usually it is a T lymphocyte mediated disease also with a subsequent IgE mediated chronic inflammation. So in acute phase, usually patients will present with a lot of redness, itching, tearing, lid edema. And in the chronic phase, it is usually a chronic surface inflammation, which is likely due to a late phase response with eosinophilia and neutrophilia. It can cause a lot of disabling symptoms, chronic ocular surface damage, and limbal stem cell deficiency as well. There are a little bit of overlaps in between the acute and chronic VKC patients, although the common features might include a bilateral disease, usually associated with giant or cobblestone papillae, Tanta spots, and recurrent history of flares. So we'll discuss the immunopathology later. Some of the clinical scenarios that I would like to discuss. This was a patient with a recurrent allergy, 360-degree limbal papillae with Horner Tanta spots. Upper tarsal conjunctiva also showed a lot of cobblestone papillae. So again, the treatment plan was long-term topical steroids, antihistaminics, and long-term immunomodulatory therapy as well. So we had to take an immunologist opinion. This was an 8-year-old girl with recurrent history of allergies, showed a pseudopterygium, which was coming from the temporal side and reaching till the pupillary border as well. So the conjunctiva showed some fine papillae, so we had to, she had to undergo a pseudopterygium excision with conjunctival autografting with an EMG. So again, we need to explain this patient about the risk of recurrence, risk of the allergies coming again and again. This was one more chronic patient, although we lost her for follow-up. She had again a 360-degree limbal stem cell deficiency with a lot of limbal thickening, limbal nodules. As you can see, a lot of scarring and pseudogerontoxin as well. We had started her on intensive therapy, but unfortunately she did not come back for a follow-up. This was again a patient who was a 25-year-old female, had almost a 270-degree limbal hypertrophy, lot of cobblestone papillae. She got a history of steroid response, had to undergo a bleb surgery, a glaucoma surgery as well because of a treatment refractory glaucoma, and also developed a little bit of posterior subcapsular cataract because she was on a lot of steroids till the time she came to us. Again, this was a very chronic bilateral case of VKC with right eye showing a little bit of pseudopterygium and a lot of scarring. Left eye again shows a 360-degree limbal ischemia and scarring. So why are we calling this a blinding disease? It is because there is a lot of chance of the corneal scarring, recurrent shield ulcers, risk of limbal stem cell deficiency, chances of advanced keratoconus, and complications related to chronic steroid use. So these are all the interventions that might be needed in all these patients. Again, this was a paper published by Dr. Sangwan sir's group, wherein the complications related to the VKC were discussed. So again, we did a lot of work on keratoconus and IgE and eye rubbing. So how do we relate IgE and its role in keratoconus. So basically, whenever there is an increase in the IgE, there is increase in the pro-inflammatory ocular surface milieu, and this causes a dysregulation of LOX, MMP, and collagen, basically the ECM. So this was our previous work. These were some of the patients who developed a very advanced KC and had a lot of recurrent episodes of allergies and needed a treatment in terms of maybe a topo-guided cross-linking, an intacs, or a surgery in terms of a keratoplasty. So what all treatments we have already discussed this. Antihistaminics, mast cell stabilizers, steroids, of course, immunomodulators, and in very severe cases, surgical options as well. So why not steroids and why yes steroids? So basically what all modes of treatment can be either topical, oral, subtarsal, or pulse therapy. But it is like an instant magic. It helps the patient immediately, and is a very fast response and fast action, gives immediate symptomatic relief. But again, there is a chance of steroid dependence, response, always a chance of cataract formation, glaucoma, and etc. So steroid sparing agents include cyclosporin A. We have already discussed the concentrations, and cyclosporin A and tacrolimus are usually used. Again, there are some role of oral immunomodulators as well. So recently we did a lot of study on systemic immunotherapy. Basically, I think Dr. Soumya ma'am will also be discussing about immunotherapy after this. The requirement of the steroid post the systemic immunotherapy reduced in these patients which we studied. So once we evaluate the patients, we need to see in the refractory cases, refer them to the allergy specialist, and in case there is an improvement, yes, you continue the pharmacological support, or in case there is no, then we have to augment with some more medications as well. So what is systemic immunotherapy? It's like applying an allergic extract to immunologically rich sublingual area. It's like a systemic immunotherapy. So I think Dr. Swami sir might help me with trialos and lipid. We'll discuss after this. Sure. Okay. Yes, sure. Okay. So some role of newer drugs on which might help in the recurrent allergy patients. Surgical interventions again include cryoablation, removal of the subtarsal papillae, mucous membrane grafting in very severe cases. Just to summarize, grading of the allergic eye disease is very important for better and long-term management. Steroid-depending or steroid-sparing agents are very important in long-term control. A step-ladder approach and an immunologist opinion in these cases is very important. Thank you.